This is Justine Sparrgrove recording Learning Plan 9 for Nursing Pharmacology, the immune system. This is lecture 2 of 2. We're going to review chapter 36, drugs for fungal, protozoal, and helminthic infections. We're going to cover fungal infections, antifungal drugs, protozoan infections, antiprotozoan drugs, helminthic infections, and antihelminthic drugs. So fungal infections. Fungi are single or multicellular organisms that's main goal is to decompose dead plants and animals, basically helping it to return into the soil. Mushrooms, yeast, and molds are all considered fungi. Fungal infections, they can be superficial or systemic. Superficial usually affects the hair, skin, nails, and mucous membranes, and they're usually treated with topical agents. Now, systemic affects internal organs and most commonly the lungs, brain, and digestive organs. This type is less common. It can be fatal in immunosuppressed clients or patients, and it's usually treated with oral or parenteral agents. And please note that fungi or fungus infections are unaffected by most antibiotics. So your clients are at risk if basically clients at risk. Human body is very resistant to fungi. Most serious fungal infections occur in clients with a suppressed immune system, and a lot of them are community-acquired infections or opportunistic infections. Systemic antifungal drugs. So there's amphotericin B, or fungazone. This is a wide spectrum use, and it's preferred medication for systemic use. Then there is fluconazole or diflucan, which you'll see used quite a bit, treats systemic and superficial fungal infections in the CNS, bone, eyes, urinary tract, and respiratory tract. And it's usually given along with antibacterials just due to the risk of yeast infections occurring from the antibacterials. And this is in the azole class, and most common adverse effects from this is usually nausea and vomiting. Then we have nystatin or mycostatin, which treats candida infections of the intestines, vagina, skin, and mouth. It's typically given when someone has thrush, and it's usually like a thick yellow liquid, and it can also be given in a powder form or in a cream form for any yeasty areas under like breasts or in abdominal folds. With systemic antifungal therapy, use cautiously with renal impairment, severe bone suppression, and in pregnancy. Amphotericin B or fungazone can cause kidney damage, so closely monitor those fluid and electrolyte statuses. Amphotericin B can also cause ototoxicity, so be sure to assess for hearing loss, vertigo, unsteady gait, and tinnitus. Protozoan infections are single-cell organisms that live in water, soil, and animals as their hosts. It causes disease in Africa, South America, Central America, and Asia. They usually thrive in areas with poor sanitation, and a lot of times travelers may transmit organisms by going on vacation and bringing them back to the United States. So that's how they really end up in the United States for us. So pharmacotherapy of malaria. So malaria is the most common protozoal disease, second most fatal infectious disease in the world, and it's caused by the protozoan Plasmodium. It's transmitted by the bite of a female mosquito, and once in the body, it multiplies in the liver and then moves into the blood, essentially. There is a nice diagram in your book if you want to kind of see how that works. It goes a little bit more into detail, but that was just kind of a short snippet of how it works. Malaria requires multiple drug therapy due to its complicated life cycle of the parasite, and chloroquine or Aralen is the drug of choice for malaria and is used for prophylaxis and treatment. So goals of the antimalarial therapy. First, prevention. So the CDC recommends prophylactic antimalarials. So we use prior to, during, and for 1 week after visits to the infested areas. So for instance, if any of you guys are lucky enough to be chosen to go to Haiti, if you apply, you would be taking these medications before, during, and after coming back or going to Haiti. for the mission trip for Southwest Tech. Treatments. Treatment basically interrupts the erythrocytic stage and eliminates the merocytes from the red blood cells. And then it aids in the prevention of any relapses a person may have, and it eliminates latent forms of plasmodium residing in the liver. The Helminth infections. So these are parasitic worms that cause significant disease in certain regions of the world. Roundworms are nematodes, flukes are trematodes, and tapeworms are cestodes. Enterobiasis or pinworm is the most common Helminth infection in the U.S. So that's the one that we see most often. And most Helminths enter the body through the skin or the GI tract. So the treatment here is targeted at basically killing the parasite locally in the intestine and systemically in the tissues and organs that they have invaded. So that covers chapter 36. So moving on to chapter 37, drugs for viral infections. Here we're going to cover HIV, heart treatment, herpes viruses, influenza, and hepatitis. Characteristics of viruses. So they're non-living agents that infect bacteria, plants, and animals. They're intracellular parasites, so they must be in a host cell to replicate and cause infection. And many viruses infect specific host cells, so they're very specific. So therapy for viral infections. They're self-limiting, requiring no medication. And some viruses cause serious diseases and require aggressive therapy, such as like HIV, herpes, and a little bit of hepatitis B. So what are the challenges of antiviral therapy? The challenges include the fact that viruses mutate rapidly, and basically the drugs tend to become ineffective because they can't keep up. It's difficult for the drug to find the virus without injuring normal cells along the way. And each antiviral drug is specific to one particular virus. Human immunodeficiency virus, or HIV. This infection occurs by exposure to contaminated bodily fluid, most commonly blood or semen. Transmission is usually through sexual activity, oral, anal, or vaginal. Contact of infected fluids with broken skin, mucous membranes, or needle sticks. And newborns can obtain it from their mother at birth or from breastfeeding. The phases of HIV therapy, really there's a latent phase, which the virus lies dormant once it's in the body. But once the diagnosis is confirmed, we need to start treatment right away. So starting in 2014, the CDC changed its guidelines to start treatment immediately to delay the onset of acute symptoms and the progression of AIDS. The negatives of doing this include the cost is extremely high. There are many uncomfortable and serious adverse effects, and viral resistance can develop. So our therapeutic goals are to reduce HIV RNA load in the plasma to an undetectable level or less than 75 copies per milliliter, restore and preserve immunologic function, increase the lifespan of someone, higher quality of life, and decrease risk for transmission from mother to child. Because unfortunately that child has no say when they get it. All right, highly active antiretroviral therapy, or HART. It's 5 drug classes that are used in various combinations. Again, so that's basically why it is called HART. So it includes the nucleotide reverse transcriptase inhibitors, NRTI and TRTIs, non-nucleoside reverse transcriptase inhibitors, NNRTI, protease inhibitor, PI, entry inhibitors include fusion or entry inhibitor and CCR5 antagonists, and then integrase inhibitors. I do want to mention that I don't expect you to know which combinations and everything that these will go into, just so that way you know. Treatment failures are common because clients are non-tolerant of the adverse effects. Clients are non-adherent to complex regimen of the different combinations they may give you. emergence of resistant strains still develop. And then there's a little bit of a genetic variability from person to person. And the therapy is always changing, so staying current with the latest treatment is the best thing you can do for your patients. Post-exposure prophylaxis, PEP. It started within 24 to 36 hours after a known HIV positive exposure. Baseline HIV RNA level test needs to be immediately done with follow-up tests in 6 weeks, 12 weeks, and 6 months. The PEP is continued usually for 4 months, and there are 3 different drug regimens. And then unknown HIV status, PEP is decided from case to case. I do want to show you guys a quick little video about Barbara Fassbinder. She was from Monona, Iowa, and was a nurse who worked in the ER at Prairie Memorial Hospital in Prairie du Chien. And she was actually the first known healthcare provider or nurse, it just happened to be she was a nurse, to contract HIV. Okay, so I'm going to try and close this here. So I'm going to follow up with me here as I find everything. Here we go. Okay, so we're just going to watch a quick video.
Exposure. Now the significance of my experience does not lie in its complexity. The significance, I feel, lies in its sheer simplicity, for you see, I am just a very simple nurse. My story begins in August of 1986 in a 49-bed community hospital in the rural Midwest. A young man came to the emergency room in acute distress and within a relatively short amount of time suffered a respiratory arrest. During the resuscitation efforts, I did something that I had done 100 times before. And that was, I was instructed to remove an arterial line that was not working. When I did so, I had a small piece of gauze available. I put pressure on the site to stop the bleeding, and approximately a half a cc soaked through onto my left index finger. And what I'd completely forgotten about is that on that finger were some very small, seemingly inconsequential cuts. I simply wiped the blood away when the time was up, and we continued with resuscitation, which was unsuccessful ultimately. The young man died. This young man, who was new in the area, for which we had had no written history available, he was able to give us no verbal history, probably did not know that he was infected with AIDS. His infection was found at the time of autopsy, and nor did his friends that brought him in that night. And although I came down with a mono-like illness a few weeks later, and I was quite miserable, I didn't connect the two incidents, and in fact felt well enough to donate blood in December of '86, as was a routine thing for me to do. It just so happened that the hospital that I worked at offered HIV testing for the 15 of us that were involved in resuscitation of this young man. And since my husband and I of 15 years, 13 at that time, had wanted to have a fourth child, we thought it would be a prudent thing to do for me to be tested. I got tested in an effort to put our minds at ease once and for all about the whole incident. Well, in mid-January of '87, I have to say that my mind was not put at ease at all. And it has turned into a sequence of events that has at times been a nightmare for myself and my family. I was called into an office at work and shown the written results of my HIV test and asked for a possible explanation. At first, I laughed at the absurdity. And as anger and embarrassment sunk in, I requested another test because I assumed a terrible mistake had been made. The results came to me about a week later. The results came to me as I was alone at home with a 3-year-old who was confused and frightened by my reactions The results came from a stranger in the health department as well as someone from a blood bank. I alone had to figure out how to explain this to my husband. I alone had to figure out how to tell him that a state health department investigation into our personal private life was to begin the next morning. I alone had to tell him that he would have to be tested for HIV as well and what that would mean. To their credit, the State Department of Health did a very thorough and sensitive investigation, and David, thank God, has tested HIV negative repeatedly since then. And I thank God for that.
All right, so we'll continue here. I'm going to bring back up our PowerPoint. I did want to show you that since it is so close to home. It's, you know, it means a lot more when it's close to home. Get to the new, where we were here. All right, so moving on, herpes viruses. They're acquired through direct physical contact with an infected person or from mothers to their newborns, and they usually have repeated blister-like lesions on the skin, genitals, and other mucosal surfaces. So drugs for herpes viruses. They lessen the severity of an acute herpes simplex infection. They prolong latent period of disease and relieve acute symptoms. And the different types are type 1 and 2, cytomegalovirus, varicella-zoster virus, VZV is what that's known as, Epstein-Barr virus, EBV, and these are all part of the herpes viruses that are treatable or have some sort of treatment to go with them. Oral antiviral therapy is usually given for 7 to 10 days. Topical forms of several antivirals are available. And acyclovir or Zovirax is the most commonly one that we see used, and this one prevents viral DNA synthesis. Influenza is a viral infection. Symptoms include sore throat, sneezing, coughing, fever, and chills. It's spread via airborne droplets, and it's designated with the letters, not lets, letters, A, B, or C. Drugs for influenza, usually vaccination is the best approach, so preventative. Antivirals are available to prevent influenza, most useful when combined with vaccines. And neuroamidase inhibitors, such as Tamiflu, is the most common one that we see used. It's very expensive though, but we do see it used quite frequently. And this shortens the discomfort period for influenza symptoms from 7 days to 5 days. And it has a limited efficacy. So really it's just for comfort. All right, viral hepatitis. Hepatitis A is actually called HAV. It's from oral fecal route, and it's most common in the United States. And then there's hepatitis B, HBV, which is through contaminated blood or body fluids. There we go. Drugs for hepatitis include viral hepatitis is caused by HAV and HBV, so Hep A and Hep B. So viral hepatitis is prevented through vaccination. Few meds are available for post-exposure treatment. It is important to prevent it. Immunoglobulin sometimes is used to confer passive immunity in a patient that was exposed. And then treatment for HIV is basically symptomatic. Now, interferon alpha-2b or intron A or PEG interferon or tenofovir, disoproxil, and entecavir are available for HBV. Ooh, went too far. All right, so hepatitis C and other hepatitis viruses, there are no vaccines available to prevent hepatitis C, and combination therapy helps with viral suppression. So the two that we most commonly see is the Vicitalis and the Incivic. So that is the end of our PowerPoint, as you could see. Sorry for the different little pop-ups or interruptions, but if you wanted to see more on that video, there is a link on the PowerPoint that you can go ahead, copy and paste in. So it's a pretty unique story, and like I said, it hits home. It's a nurse, and it's very close to us. If you have any questions, let me know.